Thank you. Thank you. It's nice to be back on a Tuesday. Look forward to covering the next set of objectives, which are, I guess, on the screen now.
They are. You're ready to roll. I'm going to go on mute, and you can take it away. And I'll be back off mute for the Q&A portion.
Very well. Thanks, Carol, for the introduction, and welcome attendees to the webinar. Appreciate your attendance. What we're going to cover today in this set of Stage 1 objectives are information and data exchange with patients. So focusing on the patient management, if you will, of their own health, and supporting that with specific objectives, 2 core and 1 menu. So let us continue. The format of this offering is similar to the last 3 in that we have a front end that, again, highlights what's the structure of the objectives that the hospital needs to consider when it is becoming compliant for Stage 1. So in Stage 1, for hospitals, there have been 24 objectives identified. They've been grouped into 5 priority outcome areas, and those are shown on your screen. The first and probably the key one, improving quality, safety, efficiency, reducing health disparities. The second, engaging patients and families in their health care, and that's the one that we're really focused on today, that kind of grouping. Third one, ensuring adequate privacy and security. And then 4, improving care coordination, and that we touched upon last time. And then finally, improving population and public health, and we touched upon those in, I think it was section 2 of this series. So the objectives are defined as 14 core, and as you recall, the core are the ones that you have to meet in order to become compliant if you're an eligible hospital or a critical access hospital. For eligible professionals, just FYI, there are 15 core objectives under state. Again, this is Stage 1, so applicable for 2011 and 12. And then there are also 10 menu objectives, and these are the ones that you get to select from, and you need to select 5 out of 10 of those menu objectives. So the 14 core plus the 5, that gets you 19 that you need to report to CMS on. And of the 5, 1 needs to be addressing public health priorities. So one of the 5 that you select out of the menu set. Okay, so the structure in which we have been talking about each objective, we go over the objective itself, or description, and then what's the measure? How do we know if we're compliant, and what are we going to be asked to provide information on when we attest at the end of the reporting period, whether, to determine if we are compliant. And then finally, noting any exclusions. Are there situations, clinical situations, that might allow us not to have to meet the objective, but still qualify under the EHR incentive program for payments? So we'll touch upon those points as we go through the 3 objectives. As far as the types of measures that are available or that are required, the easiest one is answering yes or no to a specific question, and that would be, for instance, an example would be drug allergy checking. Was the software capability enabled during the entire reporting period? And if it is, you just have to answer yes, and you meet that measure. So there's no metric or computation that has to be provided. many of the measures, many of the objectives, however, do have a numeric measurement associated, and there are really two types, and it really affects what goes into the denominator. And the denominator would be either those patients whose records are maintained using certified EHR technology, or all patients seen or admitted during the EHR reporting period, regardless of whether their health record is maintained using certified EHR technology. So those are the two types of denominators. The numerator is going to be, those patients that meet the stated requirement or objective of the measure, and their records are maintained using certified EHR technology. So those are the types of measures that are included in stage 1 objectives. As I mentioned, there are some situations for exclusions, and we'll see an example of that today. And it's typically because of a clinical situation or setting didn't occur during the reporting period for the entity, for the hospital. They wouldn't have an eligible patient that the measure is targeted at, so they can be excluded. And then exclusions do not count against the 5 deferred menu set objectives, and I'll try to translate that into English. What that means is that you can elect to exclude, you can elect to defer, get the terminology right, you can elect to defer 5 of the 10 menu objectives. Then, of the remaining 5 that you need to report, you may encounter one of those that you can exclude because you didn't have a clinical setting. So that means you only need to really meet 4. You don't have to take one of the menu items that you deferred back and replace it with an exclusion. It just reduces the total number of objectives from the menu column that you have to meet, okay? And in CMS's eyes, you sort of meet an excluded item because you don't have to, you didn't have that clinical situation. Okay, now that I've probably confused you on that point, please raise a question later if that was not clear. Okay, so let's take a look at then some of this information that we want to address, and there'll be some definitions that we cover. And the first is, and this is an important one, and it's one that's been addressed by CMS subsequent to the actual final rule being published on July 28th of last year, and that is which patients that are seen in the emergency room or department need to be considered in our determination of measures. And then, so what was clarified and actually added were 2 approaches. One, those patients that are either are seen in the emergency room and then subsequently admitted to the hospital, or that are seen in the emergency room and observation services are provided for that patient. And there's a description of what observation services are if you look at the the third bullet point under observation services method, the Medicare Benefit Policy Manual, Chapter 6, Section 20.6, and has a specific qualification for observation services. So patients who receive observation services either under place of service 22 or 23 can be included in the denominator. Now, so that's one method, the observation services method of getting a population count for the denominator. The other method is you can include all visits to the emergency department, all patients seen. And so that's, you know, another way to compute what the denominator is. And I think that there may be a strategy point here of, you know, which one yields the better result, and looking at numbers for your hospital to determine which method is best for you. But you do need to apply it consistently as far as all the different measures that include point of service 23. Okay, continuing on from definitional terms, and again, some of these are carryover from our previous sessions, but what is a unique patient? And again, a unique patient is during the reporting period if the identical patient, is admitted on multiple occurrences or multiple stays, that patient is only counted once. So that is the definition of a unique patient. And from a computation of denominator and numerator values. Business days, and you'll wonder why would we have to define business days in an EHR, but because of how certain measures were defined, it's important to understand what a business day is. So Monday through Friday, excluding holidays, federal or state, so that or evidently if there's administrative staff isn't available, then that would not be counted as well. So the calculation becomes important in one of the measures we look at today. Discharge instructions, again, directions that the patient must follow subsequent to discharge, and instructing them to take actions in their residence for the patient, or could be for home care attendants, maybe even other clinical staff at an outpatient setting. So those instructions are discharge instructions per the definition of the objective that we're going to look at today. Diagnostic test results is another term that I think we had in a subsequent previous session, and they include, but not limited, but so we cite examples of what they might be: blood tests, microbiology, urinalysis, pathology, etc. You can see the list of these: cardiology, cardiac imaging, nuclear medicine tests, pulmonary function. Those are all considered diagnostic test results. Okay, so let us look at the first of the three that we're going to look at today, and that is electronic health information. It's a core objective, meaning it's one of the 14 that we must meet. We must respond and meet the requirement. So what is the objective? Well, we need to be able to provide patients with an electronic copy of their health information, and then we qualify that by saying what needs to be included in that health information: diagnostic test results. So that's why we were specific to that list. Problem list, medication lists, medication allergies, discharge summary, and then finally procedures. And we need to provide this upon request, and that's important. We don't have to do it for patients who do not request an electronic copy of their health information. So what's the measure for this? How do we know we're complying with that objective? Well, if for more than 50% of patients, and you note that the patients are either inpatient or the emergency department for the eligible hospital or critical access hospital, so place of service 21 or 23, who gotta request electronic copy. So we need to provide that within 3 business days. So the reason why we just define business days is we can calculate now what those business days mean. So exclusions. If the hospital or critical access hospital has had no requests for electronic copies of this patient health information during the EHR reporting period, we can exclude ourselves from that measure, and we can just note it as we attest to CMS at the end of the reporting period. Okay, so let's again look at the attestation requirements. So we're going to have to provide a numerator value, and that's the number of patients who requested the electronic copy of their health record. And it's those patients that did that 4 business days prior to the end of the reporting period. Because if you think about it, we're given 3 days to respond, so only those patients that requested it 4 days or earlier before the end of the reporting period, the EHR reporting period, are counted in the denominator. Then those that are in the numerator are those that actually received an electronic copy within 3 business days of their health information. So that's how we would come up with our percentage. Again, what's the exclusion? We can exclude if we had no requests for those patients, and we say, or their agents. So if it's not the patient requesting, but if there's a valid agent or representative of the patient who requested that information, they would be included. If we had none of those, then we would be able to exclude. We'd say no next to the appropriate exclusion, and then on the CMS website, apply that as an exclusion. And again, remembering how this wording on the percentages, the resulting percent has to be more than 50%. So it's got to be 51 or higher, right? Okay, now, there's quite a bit of additional information that we want to make you aware of. The first one is, although this is one of the measures that qualifies as those patients whose records are maintained using certified EHR technology, if we wanted to, I'm not quite sure why we ever would want to, we could add other patient records who aren't maintained in the certified EHR. I guess that would be allowed. It's going to dilute the result, so I'm not quite sure why we would ever want to do that. But it is allowed. And we do have to be cognizant of, obviously, HIPAA privacy rules, specifically at the reference paragraph here, 45 CFR 164.524, which access of individuals to personal health information. What we want to be able to do is to ensure that nothing in the high-tech law is inconsistent with HIPAA privacy rules. Basically, cut to the chase. And again, the information that we provide electronically is not necessarily limited to that information that exists electronically in or accessible from the certified EHR, but that's sort of the floor. That's what we have to be able to provide, if you will. And it's maintained on or by or on behalf of the eligible hospital. So it is a minimum, if you will. Okay, some more on just the privacy points. Provider may withhold information from the patient's health information, again, in accordance with HIPAA privacy rules. I just want to pick off the key points here. The form and format of this again, we're providing electronic information, right? Should be human readable, obviously. Bits and bytes don't help unless we can translate that into human readable format. Again, complying with HIPAA privacy rules. And what's the media that we can provide this information to the patient? and we can provide it in a number of different electronic forms. Patient portals, which are becoming very popular, personal health records, which could be part of a patient portal, I suppose. You could provide it on a CD, a USB fob, which you're familiar with, that go into a USB port. So any of those kinds of electronic formats are acceptable as complying with this particular objective. And if provision of the copy involves mailing, then it would need to be mailed by at least the 3rd business day following the request of the patient. So from that perspective, the patient may not receive that electronic media by the 3rd day, but it has to be at least put into the mail system if it's a CD or a fob. Obviously, if it's a patient portal, then mailing wouldn't necessarily come into play there. A bit about, can we charge for this service? And HIPAA has a point on that, which permits HIPAA-covered entities to charge an individual a reasonable cost-based fee for a copy of the health information. And there is some additional information that may come out on this out of the Health and Human Services Office of Civil Rights, which now really addresses HIPAA, and they will may clarify or provide some additional information on incremental charges that could be, say, levied if we're providing electronic health information in a certain format. Third-party requests, that's another area that has some information that we need to be aware of as far as do we include those requests in the denominator or not. And only specific ones would be included. And I think I covered this a bit earlier. Family members or patient-authorized reps may substitute for the disclosure of information to the patient, and they would count the same as if the patient had. All other third-party requests are excluded, are not included. So it's got to be family member or a patient-authorized rep, and those requests would then again be counted similar to what a patient request would have been. Excuse me. So, and then finally, eligible hospital providing patient information they have available electronically, and at a minimum include the list of the objective, from the objective of the actual health information. So this is sort of an encouraging the hospital to provide all of the available health information, but there's sort of a minimum standard that was already defined previously on that one slide. So it's not a requirement, it's a stated preference by CMS for what information ought to be included. Okay, so that was the personal health information made available to the patient. Now, moving on, the next, and this is a core objective also, so one of the 14, providing electronic discharge instructions. And this is based, again, upon requesting those discharge instructions electronically. That's the objective. The measure, we have to meet more than 50% of the patients who are discharged from the hospital, either inpatient or emergency department, who requested an electronic copy of their discharge instructions are provided it. So we have to do it more than 50% of the time in order to meet this specific objective. Exclusion? Yes. any eligible hospital that has no request for patients or from their agents for an electronic copy of their discharge instructions. Again, it has to be during the EHR reporting period, and as we recall, for Medicare, year one, if you're filing for the first time, 2011 or 12, that's a 90-day contiguous period. So during that time period, if you have had no requests, you can exclude yourself for this particular objective. Numerator, number of patients discharged from the hospital who requested the electronic copy of their discharge instructions. The numerator, those patients that we actually provided electronic discharge instructions. And then, again, the exclusion that I just mentioned. So if we had no requests, we can exclude entering 0, and that will still qualify us. The resulting percentage has to be greater than 50%, similar to the previous objective. So let's take a look at the additional information. Again, the provider is permitted to include patients whose records aren't maintained using certified EHR technology. I'm not sure why they do that. Again, it would dilute the answer. And you want to get as great a percentage as possible. But you can include them if you choose to, for some reason. So that information must be provided electronically, and that's limited to that information that exists electronically, of course, and that's accessible from the certified EHR technology. The electronic discharge instructions themselves, in the form of electronic media or instructions on how to access instructions electronically, should be furnished at the time of discharge. So remember, for personal health information, there was up to 3 business days. No. For discharge instructions, they want those available at the point of discharge. The provider has the option of withholding information in accordance with HIPAA privacy rules, and the form and format should be human readable and, again, complying with HIPAA privacy rules. What's the form in the electronic media? Similar to the health information. It's patient portal, personal health record, could be CD, USB fob, and then et cetera. So if it's some other form that's still human readable, then that would also qualify. All right, so that one was pretty straightforward. We have the next and the final, which is a menu objective now, not a core. So therefore, the hospital could choose it could defer as one of their 5, or choose to include this as one of the 5 they're submitting. What is it? Well, using certified EHR technology to identify patient-specific education resources and provide those resources to the patient if appropriate. How do we know that we're complying? Well, if we do it more than 10%, and for all unique patients admitted to the eligible hospital or the critical access hospital, and during the reporting period are provided patient-specific education resources. And there are no exclusions on this, which is interesting. So, calculation on this, number of unique patients admitted during the EHR reporting period. So that's the total patient population. Then the number of patients in the denominator who are provided patient education-specific resources is in the numerator. The resulting percent has to be greater than 10% in order to meet this objective. So let's take a look at some additional information. The providers, again, permitted, but doesn't have to allow records of patients who aren't maintained in the count. Typically, you're going to find that the hospital is just going to count those records that are in the certified EHR. Interesting point here is the educational resources or materials, they don't have to be stored within or generated from or by the certified EHR. Now, providers should utilize the EHR technology where technology suggests patient-specific educational resources, based on information stored in the certified EHR. So in other words, we don't necessarily have to store that educational material in the certified EHR. We need to be able to identify what that material is and where the materials are available. And so, the provider really can make a final decision on whether the educational resource is useful and relevant to a specific patient based upon that specific condition. But the suggested materials, the EHR system needs to be able to provide that information.